Welcome everybody, and thanks for joining us for today's Spotlight on webinar. My name is Dan Richter and I've just stepped in on behalf of Dr. Andrew Gibbons. So I've been involved in some evidence for quality improvement stuff, but actually I work at University Hospitals Dorset, so that's Bournemouth and Poole and Christchurch hospitals, which have now merged. Evidence for quality improvement, or evidence for QI, began life as a Q Exchange award-winning project, and then since then it's been granted further funding from the Q community supporting Q Connections programme. And the mission for it is to equip quality improvers across healthcare with the knowledge, evidence and best practice that we need to make better decisions and deliver better outcomes more efficiently. Today we're delighted to welcome you to the second of our Spotlight on sessions. And these Spotlight sessions are one important part of the programme of events that we've had planned over the coming year. The next one, just to mention, is the 15th of December, 1 till 2, so look out for invitations to that one as well. We're also running monthly 1-hour bite-sized training sessions focusing on specific QI tools, and we're doing in conversation with sessions with authors of QI research papers, as well as randomized coffee trials, tweet chats and peer support groups. So there's a lot going on. Each Spotlight session, so these ones, will feature a different team or organisation from across health or social care, and it's showcasing their story of how their organisation is delivering quality improvement. And we just hope that you find it a fantastic opportunity to learn from different people. So in this session, we're delighted to welcome the QI team from Connect Health. And the session will be led by Andrew, who's a consultant physiotherapist and head of MSK at Connect Health. He mentioned earlier he's doing a PhD, which I believe is at Keele University, looking at the use of diagnostic imaging for common musculoskeletal conditions in primary care. Just quickly before we go over to Andrew, Connect Health, if you haven't heard of them, I hadn't heard of them. They are a leading provider of community services and the UK's largest independent musculoskeletal and pain services provider. In terms of scale, they serve over 375,000 NHS patients across more than 55 NHS partners and more than 100 occupational health wellbeing services. Over the course of the next half an hour or so, Andrew will share with you his story of the implementation of a strategic QI group across this national provider, from the inception to the present day, how they set the group up, the enablers, some of the mistakes they've made and lessons learned, hopefully, and impact that the group's had. And so, as I said, we'll have time for questions at the end, but we'll hand over now to Andrew. Thank you, Andrew.
Excellent. Thanks, Dan. Probably you know more about Connect than I do by the sounds of things. But no, thank you for the introduction. Am I okay to share my screen to bring some slides up? I'm working off one screen, so if I look like I'm vaguely looking into the distance, it's because I'm trying to orientate and I can't see what I look like. But here we are.
No problem.
Cool. So hopefully you can see some slides.
Yes, we can.
Excellent. Cool. Thank you for the invite, Dan, and obviously Andrew as well, who's not with us today. I probably won't take up the full kind of half an hour in terms of taking you through our story, and hopefully it's very much that a story, and it's been great putting these slides together as an opportunity to reflect, both on things we've done well and also some things that we didn't do so well, and it with anything with improvements, obviously it's not quite finished, and I don't think it ever will be, but those cyclical processes that we've put into place, and just give you a bit of a whistle stop tour really over like kind of the last couple of years of what we've been focusing on. As mentioned, I'm a physiotherapist with a speciality in musculoskeletal, so that's kind of bones, joints, nerves, those kinds of things. And by no way would I commit to being an improvement methodologist or an improver, so to speak, but very much looking at this from a perspective of a clinical point of view, but also how can we help clinicians to become more familiar, better, kind of enabled and by proxy apply kind of quality improvement approaches to improve safety outcomes and experience for the patients that we serve. And that was very much the kind of the starting point. So I thought I would take you through the kind of background, and if you wind your minds back to pre-COVID, this is kind of what was occupying my mind the month before lockdown. Now, as Dan mentioned, we see a fair number of patients, and as an independent provider, we work across England. So we work with somewhere between 50 and 55 CCGs. It kind of varies, but we are largely a business. But with that comes opportunity, and with that comes challenge. So business structure and function is kind of readily felt. It parallels how kind of trusts are set up. They're of course businesses in nature, but it kind of highlights some of the kind of the path we had to kind of navigate through in order to set this group up. So back in kind of February 2020, I just moved into a senior role within the organisation, and when you kind of scratch beneath the surface, what I found was that we had good intentions around quality and around governance, and we had a solid foundation, but mostly focusing on assurance rather than looking at not only assuring but translating that forward into how can we do things better. So a solid foundation, but our approach to kind of how we improve things was largely fragmented. And if I was going to kind of grade it, I would give it a could do better. We had groups within our kind of infrastructure that didn't really function. We had policies in place, but without clear ownership of those policies, or really an ability to kind of look forward and see what was coming down the track that might impact upon our clinical delivery, either how we set up services, how we delivered care, or kind of how we responded to these kind of external influences. At the same time, particularly from that clinical point of view, external kind of governance structures, both from NHS England and Health Education England, as well as now kind of obviously together, were defining capability for clinicians working at an advanced level, so advanced practitioners, and also a consultant level as well. And there was a clear need for our clinicians to be more familiar with how to apply improvement methodologies, but also how to do that meaningfully in a structured way. To kind of zoom in on this, I'm mindful that I'm speaking from an MSK point of view. So just to really highlight where this kind of filters through in terms of the framework, this is the core capabilities framework that outlines that clinicians are expected to be able to apply national guidance, to monitor and evaluate outcomes to improve quality, as well as engaging with clinical audit, service evaluation, and research. So my role within the organisation is both to represent clinicians at a senior level to ensure we're involved in decision making, ensure that the structures and infrastructure within the organisation works for us and by proxy for our patients, but also to set the conditions by which, as an organisation, we can enable clinicians to be able to undertake such these activities. And obviously, working in healthcare, it's tricky at the best of times. It's been particularly tricky over the last 2.5, 3 years. And time and headspace to kind of get away from the kind of the coal face of delivering care to kind of look up and look out in order to work more effectively and better can sometimes be limited. So it's really about making a case of how do we embed this into our culture, so that it becomes business as usual as opposed to something else to do or something we're trying to shoehorn in. So hopefully kind of painting a bit of a picture of where we're working. Likewise, just to kind of feed that forward, this is the advanced practice framework, and highlighted in yellow and red, I think hopefully appeals to all of us on this call in terms of this real kind of silver thread of audit, improvement, service evaluation, knowledge translation, and the ability to understand that and apply that kind of coming through, which is excellent. And also outlines that as well as the ability to kind of implement robust governance systems or disseminate learning and findings, but it's also about working proactively to close the kind of research to practice gap. And speaking from a clinical point of view, that's largely where I think quality improvement has such value in terms of translating research or translating knowledge into practice, helping to close that gap. So if we can get, and the approach we take, if we can get more people speaking the language, being familiar with and thinking from that improvement lens, then that should help us apply new findings and evidence into practice. That well-quoted stat, isn't there, that It takes 17 years for kind of new research to become embedded within practice. So hopefully this kind of cuts down that time. And when we start talking about kind of the impacts of some of the work we've done, and hopefully we're kind of making a meaningful contribution to that, both inside the organisation and outside. So largely what I'm trying to say, is there's a clear mandate for clinicians to be involved with, be aware of, and to be better supported and enabled to engage with improvement activities. So as I mentioned, we had a fairly solid foundation. So I was starting this piece of work, or leading this piece of work from very much on the shoulders of others before me. And what did that solid foundation look like? Well, we had an annual audit program to begin with. That was useful. Each of our services, we have about 20 services up and down the country, but it focused on topics such as use of diagnostics, so MRI scans, X-rays, that kind of thing. That's the provision of things like injections and injection therapy. It had all the classical stuff such as clinical records audits and infection control audits, so on and so forth. But what was really clear was that we were using audit as a means to monitor or to assure, which is definitely needed and required, and part of good governance. But we weren't taking that next step of the so what. What's the actions from this? What's the learning from this that drives improvement, rather than just patting ourselves on the back and saying, yeah, we're doing a good job, but how can we do a better job? Looking at the kind of lay of the land, there's fairly limited time within the kind of the national kind of governance infrastructure to get into the detail of the audit findings, to identify themes, to identify trends, both proactively as well as kind of retrospectively where appropriate. Root cause analyses weren't being done, and actions were fairly trivial. Feedback given, more training required. The actions didn't flow through from the roots, and likewise there was no accountability in terms of who owns that action. No one holds to account in terms of when it was to be delivered by, what's the impact of that action, have we got the right action there, or do we need to change course somewhat? So on paper we had an audit cycle, but we did not have a robust approach to improving quality, and by proxy didn't have a tangible approach to one that was defendable and effective and making a difference to patient care. And that's largely where kind of the perspective that I wanted to come at it from. So to address the kind of gap that existed, moving kind of into the what, I kind of put forward a proposal, and I proposed this group that I termed QIPP, and one of the mistakes I think is trying to make it a bit too broad, but it kind of works. But it stood for Quality Improvement Projects and Policy. And the function of this group was largely to provide strategic direction and oversight to our improvements in a non-linear fashion. And hopefully the image on the right-hand side kind of picks that up. And what I mean by kind of a non-linear fashion was just really to highlight the interdependencies across what identified as kind of 4 key areas. So if we think about research, new knowledge, it might inform guidelines, so clinical practice guidelines that say to clinicians and organisations, this should be the care that you're delivering. Those research and guidelines in turn inform our policies and practice, which then audit against to check compliance and to highlight gaps. Those gaps then analysed to obviously find the root cause, which might have either kind of clinical or operational or governance implications or requirements. There might be a training need, or there might identify the need for a piece of quality improvement work to either find or test the solution, or it might even generate a research question that suggests this gap requires the generation of new knowledge. So we can start to think about how what we're doing has a so what, it has a play forward, and it guides us somewhat in terms of what do we do with the information that we found. So having proposed this group and kind of understood the what in terms of what was required to close the gap, we needed to kind of work out the how. So it's all good and having this in theory, but how do we turn this into action, and how do we deliver it within the organisation in order to enable that culture that I've spoken about? So the how, largely to begin implementation, we started off by mapping key stakeholders in order to outline the required membership of the group. And the membership of the group has been integral to enabling the impact that the group has subsequently had. So I wanted to ensure that there was clear lines of accountability, to ensure there was multidisciplinary team clinical input, to ensure there's operational representation that largely then made up the core of the group. And that's then complemented by both governance representation as well as learning and development representation, so that we could start to feed in learning from incidents, complaints and compliments, as well as how we then embed that within the kind of the curriculum streams or the training streams that make up our learning development. So we refer that internally as our clinical academy, and now just academy, it's like a wider lens than beyond just clinicians. We also co-opted members of our senior management team, so kind of directors from across the organisation, as well as our executive team. So those that sit on the board, from our clinical director through to our chief medical officer, so that we really close the loop to ensure that they were aware of our performance, how we're performing as a clinical organisation, but also to give us that necessary top cover in terms of adequate resourcing and ensuring that what we were doing bi-directionally kind of fed into the kind of strategic input of the organisation. So there was synergy largely. So having started this piece of work in February 2020, kind of launched the group in August of the same year. So launched it in the midst of, could be somewhere between lockdown 1 and lockdown 2. I think August 2020 was kind of eating out to help out. So we weren't eating out, we were proposing this group. And we developed some aims for kind of the first year. And that first year aim was really just to embed the required infrastructure to assist the QIPP group to deliver on its objectives. So this involved the kind of usual as you would expect, an agreeing of the terms of reference. But then from there, we also developed an audit strategy that not only focused on assurance, but also driving our quality improvement. So a real kind of tactical change there was within our audit kind of templates, we ensured that there was a clear section that said, right, this is where you put your root cause analysis. From your root cause analysis, what are your actions? We expected to see them flow through. So we set the conditions for those completing the audit to really be thinking into that direction. And this is largely where having the senior management and exec representation was key. So our audit performance is reported to the board on a monthly basis, and it always looked very positive. There was lots of green RAG ratings, but we undertook a piece of work fairly early on that looked to understand how each of our services performed against clinical metrics, so kind of outcomes, experience, that kind of thing. Operational metrics, so waiting list, time from referral to appointment, and as well as kind of financial metrics. So how much was it costing us to kind of deliver the contracts? And what we found was huge variation across our services. And some of that variation was warranted, but some of it was unwarranted. And then to sense check, the first place we looked was our audits, but they all looked great. So that didn't really explain, nor did it detect the variation that this piece of work had uncovered. So what was really clear was that we had to tighten our audit methodology to ensure that it was robust. But with this, we anticipated that the lovely green-looking audit dashboards would begin to look red or amber. And it was at this point that I started to sound, probably still sound a bit like a second-hand car salesman, where I was trying to assure the board that, yes, look, our audits look worse, but I promise you they're in fact better. But having the space to do this work, forward look, and upwardly informed to ensure there was that top cover at SMT and exec to say that our audit performance is going to look worse on paper, but the reason behind it does ensure that we're actually got a better sense of how we're performing, but more importantly, identifying where the improvement need is. We also developed a research strategy that outlines our intent, and through that, a subsequent development of a research policy and the associated processes to get from proposing an idea to delivery. We developed a tracker of external guidelines and their expected publication dates to allow us to get ahead of the curve. And we also reviewed our learning and development curriculum to ensure that audit, quality improvement and research literacy were woven through the kind of the organisation, so not just in clinical roles, but also in non-clinical roles, and not just in advanced practice or consultant level curriculum, but from new grads as well. So when our new grads join the organisation in their first year, they are being taught audit methodology, QI methodology, and how to take an idea from start to finish. To test and encourage the embedding of kind of quality improvement within our culture, we set each of our kind of 20 services an objective for the year, and their objective was to design, develop, and deliver a piece of quality improvement work, which we then tracked and monitored through our QIPP group. And alongside that objective was naturally training and reflection in order to be able to develop the skills needed to deliver on that piece of work. Now, what was quite key here, and this is something that kind of came fairly late in the day in terms of our planning, but this has been something I think has been really integral. With each of our services having a quality improvement objective, we decided this would culminate in a showcase event, where in year 1, so 2020-2021, this showcase was attended by the members of our senior management team, and all of our services then took it in turns to share their project, the challenges that they faced, but then most importantly, the findings and where they're up to. And the steer was really clear with this, that you don't have to have solved the problem. Improvement work doesn't work like that. As you know, it's always cyclical. But what we wanted to see was where you got to, what the next steps were. And the idea being that people not only developed capability in terms of presenting, so we did it in a kind of a rapid 5 format, but also we were sharing learning. So essentially the service A might look at one problem, service B might look at another problem, but you can edge your bets that both services have got the same problem, and it just allows us to better use resource but share that learning. What then happened was that it was so successful we decided to repeat it. So again, 21-22, each of our services had an objective, but this time we were feeling a bit confident. We invited the exec to come and join. And the purpose of having the SMT and the exec there was largely kind of upwards management. They could see what we were doing, and so they could be assured that we weren't sitting on laurels, we were driving things forward and also aligned with kind of strategy. But also they performed the role of a judge. So they dropped off the Teams call and judged what they thought were the top 3 projects. Those top 3 projects, having presented that rapid 5 format, followed up with some questions, we then supported those top 3 each year to submit their findings for publication, whether that be from a peer-reviewed journal or to conference. And then the organisation, so Connect, paid for the conference attendance fee, gave the time to attend. And the idea, therefore, was that we were thinking upwards, sideways, and outwards. So upwards, as mentioned, the SMT exec could see what we were doing, and they think, right, this is worth resourcing, it's worth being part of our infrastructure. So it continues to ensure it's embedded in culture. Sideways, that peer support, the opportunity to kind of share learning, share challenges, share improvement and strategies to overcome, but also outwards. So by ensuring we were not just keeping this internally, but taking it to conference and publishing, and similar to this kind of webinar this morning, to share that learning externally, so that we're able to not just improve the care that we provide to patients in our space, but hopefully to help similar services or organisations and do the same, and by proxy, not make the same mistakes that we made. So what did we achieve in the first year then? So I kind of mentioned that our first kind of year aim was really just to kind of embed the infrastructure that in time meant quality improvement became part of our culture. Well, I'll put it up, our most proud achievement was it coincided at the end of kind of midway through year 1, we had a CQC inspection, which we were rated good overall, but we were rated outstanding in well-led. And these are some comments in italic from the CQC report, where the inspectors had largely allocated our kind of well-led analogy to our focus on culture, governance, and that proactive looking at improvements. That was great, but with a clear reference to the activity of this group. Additionally, we saw our audit approach tighten. It did become more robust, but it also, more importantly, started to serve that function of both assuring what we did, but also driving quality and driving that improvement, which was what we wanted. And it did have to kind of continue to sound a bit like a second-hand car salesman. At first glance, audit performance did look like it dropped off, but I think having the SMT and exec see what we did through our showcase event, they were probably a little bit more appeased than me just kind of giving them assurance that we're doing it for the right reasons. What I suppose the other aspect of this, from a cultural perspective, and from that position that I started from, that enabling clinicians, in that first year, in terms of our QI showcase, it transferred through into a number of peer-reviewed publications and submissions. So we had 12 papers accepted for publication in peer-reviewed journals, both a combination of QI and research. One of the QI projects was developing a risk stratification tool during kind of that peak area of COVID for musculoskeletal conditions. So what was important for somebody to come in? Where did the benefit of coming in for a face-to-face appointment outweigh the risk, and vice versa, to improve clinical decision making? We made that available to similar musculoskeletal organisations to help with that stratification of care. And that was published in the BMJ. And we also undertook a quality improvement approach to student placements during the pandemic. So largely setting up non-traditional placements, virtual placements, and we published that in the BMJ quality as well. We also submitted 7 submissions to conference, 3 of them being out of that showcase to the top 3, and the 7 we submitted were all successful in being supported. And part of the kind of setup of the showcase to do so in a rapid fire format was that the conference that the pieces of work were submitted to were into that rapid fire section. So it was largely a bit of a lift and shift. It meant that people didn't have to do work twice, but also got a bit of a practice. They got some feedback, so they could improve if they needed to, and also got familiar with answering questions off the back of their rapid presentation. And probably most pleasing is that if we think about those kind of total 19 examples, it clearly demonstrates an improvement in care quality. So it delivers the impact we were really hoping for. And that's largely been enabled just through time, space and commitment to not only audit, but also that play forward in terms of improvements and making sure it's embedded within our culture. So to hopefully kind of summarize and spend a bit of time more on kind of questions and discussion, I was kind of hopeful that this kind of high level summary of the work we've undertaken over the last kind of 2.5 years has demonstrated that it's really possible to make a difference to patient care and outcomes quickly if you employ a strategic approach to kind of improvement work, but ensuring that it's resourced appropriately. So whether that be through membership of the groups, you've got the right people around the table, whether it's space, whether it's time, whether it's embedded within any kind of governance or organizational structure, if you give something focus, it will realize the benefits. There's been a palpable step change in our culture towards improvements over the last kind of 2.5 years or so, and there's no doubt that QIPP Group has kind of contributed to this, and you can see it just in kind of conversations in terms of, rather than just saying things or saying ideas, people are kind of thinking a little bit more analytically in terms of solutions or how they might take that forward, and it's spread across our organisation. So whilst this is largely from a clinical perspective with a bit of an operational and governance tinge, the kind of operations directorate within the organisation are now doing similar, so supporting their operational managers in terms of continuous improvement approaches. You can clearly see the impact that it has when people are more familiar with it, when you give it space and when you give it time. And that change in culture delivers a clear and direct return of investment, as has been demonstrated here, but that indirect return investment in terms of principles being understood, applied on a day-to-day basis, particularly in the front line, particularly clinically, there's real kind of indirect benefits that have been realised also. So I'll stop there and open up for kind of feedback and questions, and particularly keen on what you think our next steps might be, particularly thinking for that kind of that concept or ethos of improvement. And if you have any questions that we don't pick up in the Q&A, or if you're watching this back as a recording, then please don't hesitate to reach out and contact me. My email address is there, and my Twitter handle, which I'm probably a little bit quicker on than I am email, at the bottom. So thank you.
Thank you, Andrew. That's brilliant. Obviously, people have had a chance to note down the address, and it will be on the. Maybe if you just type it into the chat as well. But it's great that we can now see each other rather than the presentation. So if you have a question, stick your hand up. I've got a couple, but I don't want to monopolize it. You can either stick your hand up or post it in the chat. people are shy. So one of the questions I had, Andrew, was when you described the kind of, I don't know what it would be, like a committee of people that were involved in this QIPP. It seemed quite senior, and I just wondered, and then obviously you went on to describe how you set the challenge for each team or service to design and run its own project. But I wondered, you know, that could be seen as, depending how it's run in each service, it could be run on quite a managementy type hierarchy. So it could be the leader of that service who's then controlling that project. So was that the case, and or did it vary, and how do you get away from this being senior driven and something that's imposed on people, or was it something like that?
Yeah, no, really good question. And I suppose it was kind of set up kind of purposefully in that way. I think it was one of the crucial enablers was to have that senior representation to get buy-in and to largely to begin with. We're currently going through a kind of review of the group in terms of our terms of reference, our membership, to make sure that it's still fit for purpose. And the seniority of it may drop down a little bit as it's become a bit more business as usual. But in terms of finding time, space, and support for the activity we wanted to do, I think it set the tone. This was important. If your CMO and your senior representatives are saying this is important, as an organisation, this is going to become our part of our culture, I think it shows that it's an important thing. It's not something that's just coming along and then going away. So I think it helped to set the tone. In terms of trying to keep it away from being kind of management led or senior led, I think that the real benefit of the group was getting out of the way. So we set the objective, but the objective was very loose. It's like, identify a problem or an area for improvement. In parallel, we essentially on a number of quality improvement training events, as well as signposting different resources that people could engage with. So trying to set up that kind of capability. But beyond that, it was largely left to the kind of the services to deliver. And what was really clear was those services that had taken that broad objective and included their team in I think about, okay, where are the problems, what's important for us, how are we going to identify those problems, and then took a team approach to improving them, had a better project, it was more likely to finish, it demonstrated a better impact. So I don't think it felt senior led on the ground beyond the strategic group that kind of set the conditions and gave the direction was senior. But in terms of delivery of the project, what they chose to do, how they chose to do it, methodology they employed, what they focused on, was very much at a service level. There was senior support if they wanted it, but at no point was there a sense of, right, in a month's time, let's have a meeting and let's track your progress. It was largely kicked off. Our financial year runs July to June. They knew the showcase was in April, so it kicked off in July and just said, be prepared to present something back in this format in April. Over to you, and we got out of the way.
Yeah, thank you. I think we've all experienced that some people will do it grudgingly because they have to do it, and they want to just fulfill a task as opposed to involving the team.
Absolutely. But, I suppose when we kind of talk about the indirect return on investment, year 2 in terms of the showcase event, you can see people thought, oh, this isn't just something we're doing and it's going to go away. Oh my god, there's a second one. And the last time I did it, I haven't put as much energy or effort in compared to Circus X, and obviously a little bit of competitiveness kind of kicks in. But what's pleasing to see is just then subsequently to that, this year we haven't put a service objective in. So we did it for 2 years, third year, so we're not saying you have to do this, but the number of services that are still doing it off their own back is probably greater than 2/3. So that element of just embedding it in culture, and this is something that we do, has been that for me is an indirect measure that this is something that's starting to take hold. And you can even see it now in some of our kind of our huddles when there's a problem, something's not working, and rather than say this isn't working, or so a tangible example being our kind of gym classes or group-based classes. there's variation in terms of uptake, outcomes, attendance, DNA rates across the organisation. And in our huddle, people say this isn't working. So what we're going to do about it is we're going to do a bit of a deep dive and we're going to understand. And we think we can apply a couple of cycles of QI, and we're going to come back to the group and tell you what we found. And that element of just change of nomenclature, these are frontline clinicians that, you know, 2 or 3 years ago would just be like, there's a problem. What we need to do is X, rather than spending that time understanding the problem. That's just really pleasing to see. So that the kind of the goal of making this part of our culture and our business as usual, it's not 100%, but consider if we rewind the clock 3 years, it's definitely palpably changed.
Yeah. So yeah, I take that point about we are what we repeatedly do. So that the more you carry on and show people that these projects through their peers that these projects work, that then you do get that competitiveness kicking in. Yeah,
yes, right.
It's good. And you know, we may not be the same sort of structure as Connect Health in many of our organisations, but obviously we have wards, we have departments, and so on. So yeah, that's valuable. Have we got anybody else wants to ask a question? Pop your hand up or unmute.
Done silence.
Claire.
I've got a question. I mean, it's really impressive how you've made change in such a quick period of time. So I just wonder if you have any tips, any insights into how the staff were able to do that, because it's something that we come across, you know, people just don't have the time or the headspace. So do you have any tips? Have you got any pointers in how you achieve that?
I think the key one, two I've kind of alluded to already. So the fact that the service had an objective was helpful. It gave them something they kind of had to work towards. And I do think that the fact we set it up fairly senior to begin with, set the intent, and this is something important. So I think those were key enablers. The other kind of key enabler that we had was providing the time for it. So that point of having the resource required to be able to do it. And largely then thinking back about why the representation of that core group was important, having the operational representatives, the person that counts the beans and sorts the time and make sure that clinicians are seeing patients, could see that this is an investment to save. You know, yeah. You could get your head down and see a number of patients, but if you're making the same mistakes, or you've still got those friction points, or your flow is not optimal, you might take a hit a little bit in the short term, but in the long term, you've got clinicians that are thinking about flow. You've got patients that are thinking about, clinicians that are thinking about flow, thinking about ways we can improve things, how we can minimize DNA rates, we can maximize attendance in a group, for example, which all ticks the operational boxes. So the way we did that is probably around the same time, we moved our professional development approach, changed our professional development approach. So as an organization, we committed for a number of years that clinicians would have 10 study days per year, which equated to just shy of 75, 80 hours. But the clinicians were rubbish at using these study days. We are terrible at doing it. We'd moan we haven't got time. We'd moan we haven't got time to go on study days, but we just didn't really utilise what was available to us. And largely that was because it was too clunky. So what we decided to do was change our professional development approach to having annualized, a bit like annual leave, and it was individualized. So then you've got 85 hours of professional development time. I think I mentioned in my presentation how there's a mandate for clinicians from advanced practice and consultant level practice and the standards to become familiar with this stuff. So it was trying to ensure that people realised that professional development was more than just becoming a better clinician in the kind of reductive sense of the word. So doing a course on treatment X or diagnosis Y, but in fact, it's blocking that time, using in professional development to become more familiar with improvement methodology, to undertake a QIPP, to undertake an audit, is really good development time, but also helps you to become a better clinician. So making awareness of those interdependencies, and we're still not great at taking and utilising the time that we've been given to be able to do that, but we're starting to see a bit of a sea change. We're definitely not there yet in terms of people realising professional development is quite wide and quite broad. So I suppose answering your question directly, ensuring that we had the right people in the room to see this is important. The fact that we've demonstrated this is an important activity for the organisation. Then thirdly, set the conditions for people to have that time to be able to do it and recognise that as time well spent. I think that's been quite key.
Yeah. And I just have one more question around patient involvement, and do you get service users involved in any of your changes?
Yes, absolutely. So we have a patient engagement lead. It's probably not the best title, and it's separate to this piece of work, but kind of parallel quite nicely. In that we developed what was referred to as a patient engagement toolkit. So our engagement leads, and it wasn't just about engagement, because obviously engagement is one aspect of things, but that kind of co-production ladder. So they were clinicians. Well, so we stood up, we got out of the way in terms of how services delivered the change or their improvement. But one of the sessions was focused on co-production and the co-production ladder, and what does appropriate involvement look like. And an example of this, essentially, an example of this, which would be quite interesting. So one of the services, their in quality improvement project looked at their KPIs. So KPIs, typically from a contract, I'm sure most people are aware, how many days to triage, how many days to referral to be received from A to B. But they kind of looked and thought, well, how much of this really matters in terms of quality and what we're here to do? So either patient outcomes and patient experience. So they undertook some co-production work to work with patients in the local area that said, we want this is what we're currently kind of measured against by the commissioners and whatnot. What do you think? And it was largely that they're like, we don't really care if you triage it in 2 days or 3 days. What we care about is, are we getting better? How involved are we in terms of decision making? How involved are we in terms of representation? So looking from a health and equalities perspective. So the service leads worked with the kind of this kind of patient group to develop a proposed set of KPIs. Went back to the commissioners and said, we've done this piece of work. We know we can't do a wholesale change, which is kind of a lift and shift. Why don't we prove concept and essentially change a couple, apply some cycles of where they can learn and measure things better. So, for example, health and inequalities. Initially, it was done largely on things like ethnicity, diagnosis, age, that kind of thing. But after it was demonstrated that this is A, meaningful, and B, possible to capture, the next iteration was to work with the CCGs to get kind of postcode readers. So now every referral that comes into the service is classified by postcode, which is linked to the amount of deprivation, and it gives us a bit of a spread in terms of the service or the population that we're serving. The next step in terms of cycle is then thinking around, well, we've got a KPI now that says, are we seeing the right people? We're not just seeing the people that are the higher demographics. We should be, for our population, seeing the kind of the for use of a better word, kind of bottom to lower third. But what does that mean for outcomes? So the next layer is, okay, so how do we layer this on top of outcomes? And the outcome will be the next change in KPI. So starting that off from a piece of work with patients and now seeing that come through, it's completely overhauled their set of KPIs. It's less about process and more about purpose. So what we're there to do, deliver a service, is to improve patient outcomes and patient lives. It's not about how quickly we get a piece of paper from A to B. Yes, that's important. It's an enabler, but is that really judging what we're there to do? So yeah, that's a fairly, I'd probably say, rare example. It's definitely something we need to do better, but there's a flavour of that coming through, and that's really nice to see.
That's fantastic. Well done. Thank you.
Thanks, Claire.
Yeah, that's really, really interesting, because I did sort of note that when you were talking about outcomes, I thought a lot of those were outputs, really, in terms of CQC ratings and stuff. But that's kind of answered one of the questions I would have had, really, about and about patient involvement as well. It's very interesting. In terms of sort of spread and sustain, obviously one of the stages of QI is spread and sustain. So you work with NHS trusts. What, as well as perhaps it's two parts. So there's the kind of framework which a lot of us may not be in a position to change, or may need time to think about and change. But there's also the services as they are, and for what you deal with, MSK, how would you say you could apply these lessons that you've learned to our NHS trusts?
Yeah, no, that makes perfect sense. I think twofold, and if I relate them back to what I thought was really important and what's kind of been key enablers for us, one, I think it's, well, to get back a step, we don't have currently kind of an improvement team, a research function or anything like that kind of delivers our change. So we kind of had to take this on ourselves. So if we wanted to do it, if that was important, we had to do it ourselves. That largely came to kind of making the case of why it's important. So kind of bi-directionally, part of making the case was leaning on the fact of, and a lot of NHS trusts have improvement teams. Maybe there's something in this. So that's the kind of direction we want to kind of get towards. But I think there's kind of pros and cons in terms of some latitude that we have without having kind of improvement, because we could build the case a little bit more. And we managed to build that case to a senior level. I think if I think back to where this started from, and that was largely as a clinician thinking about how do I represent and enable clinicians to do this better. I think it comes down to making it meaningful and not feel burdensome. So I've already talked a little bit about kind of protecting time to be able to do this, which I know it can be a luxury. However, that investment to save concept I think is really important, and also the quick and iterative nature of QI and demonstrating that there's change and change quickly as opposed to a project which can be a little bit slow and kind of filter off. So I think channeling those principles and understanding the differences from a clinical point of view it is really, really important. And then that flavour of different approaches. So most clinicians are familiar with kind of PDSA cycles, but as we know, that's not the only thing out there. So sometimes you have to start small and prove concept. So for example, the 15-second, 30-minute approach really struck a chord with all of our clinicians. And that's something they could readily implement and readily identify. And like anything with change, if you get a quick win, you can then start the process of embedding it in culture. So I think for busy clinicians, the lesson I would take from this is the familiarity with QI, quick wins to demonstrate where its impacts, and probably aligned to familiarity is that being abreast of a range of options. And in those early stages, the ones that are fairly simple to understand and quick to apply, I think is where you kind of get your hook. And once you've got your hook, it's easier then to kind of take people through more of the, not necessarily time consuming, but maybe more robust or methodologies you would apply to a bigger problem or a bigger area of improvement. I'm always thinking it back to what does this mean for the patient and what does it mean in terms of kind of your care. So hence where I think that 15-second, 30-minute is really struck a chord. Something is simple. Again, a tangible example, the number of times we would use like an exercise-based platform that sends exercises out to patients. If you get the email address wrong, that causes a massive chain of events. The person has to phone up the administrative team, email the clinician then has to go back into that patient record in the middle of their clinic, remember what the bloody hell that was going on, design that, get that treatment program, get the email address, probably by calling the patient up, setting it off. If the person's not really that way inclined, there might be a complaint in it, and that complaint means that the service manager has to deal with the complaint response. So taking that 15 seconds to check the email address, either getting the person to type it in, send it, check it on your phone before you leave the clinic room, has been, as soon as you could use that, a similar example to clinicians, a light bulb moment. Oh, yeah, it does say it's bloody annoying when I have to go back in on my lunch break and resend an exercise program. If I did just take that 15 seconds, it would pay dividends that in the long run. And then, well, that's QI, that's quality improvement. And you've got all these examples around you on a day-to-day basis that you can make significant improvement on. So sometimes just making it strike a chord, make it familiar, and kind of making it make sense to clinicians, I think is important.
I think that 15-second, 30-minute, I hadn't heard of that, to be honest, myself, but just very quickly looked at that. It seems like it might be quite powerful. And as you say, it's not everything has to be run as a project. And in fact, you know, you were saying most clinicians are familiar with PDSA, but not everything has to be PDSA either.
Yeah.
So yeah, no, that's quite helpful.
One of the new grads so as I mentioned, we do a QI session for new grads, and the first one we teach is 15-second, 30 minutes because it's easy to implement, understand, and kind of get buy-in. And they went away and they said, well, why about if we put a whiteboard in the clinic room So when we're doing education with people, or we want to kind of demonstrate concepts, that gives us an opportunity to do so rather than on a bit of paper. The person can take a photo of it if they want to, and it's fairly simple to do. And so they're now taking that forward as thinking, well, if we look through our kind of our friends and family test feedback and the kind of qualitative analysis with that, how many people talk about not understanding or weren't quite sure what the next step was? And their idea is, well, if we put a whiteboard in and we utilize the whiteboard, and could that mean that we get a better understanding of patients? So it obviously could be mindful of kind of causation, but they're going away now. It's fairly simple to introduce. And they will utilize that as their kind of method of kind of picking up impact. And that's come from someone who is 2.5 months qualified. So hopefully they're starting to see that these small changes, particularly when they're kind of intuitive, can make a big difference. And when you add up those small changes, then for me, the key aspect is we've got a culture of thinking clinicians that are thinking, how can we do this better? And they feel empowered to make those changes. And you say, it doesn't have to be a project.
Brilliant. We've got a few minutes left. If anybody has a question, ask now. No, I don't think we have any more questions. So, Andrew, is there anything else you wanted to cover before we wrap up?
No, I don't think so. Just say thank you for the opportunity. Like I say, I'm not an improvement specialist by any strength of my imagination, but I really think there is synergy between clinicians, clinical practice, and improvement and value, increasing in familiarity and having that within our culture. So thank you for letting me be kind of interlope as a non-improvement specialist, but hopefully haven't completely, done myself a misjustice by by misrepresenting anything. But it's been great to reflect on it with you. Thank you.
Thank you, Andrew, and thank you to the Connect Health team for your presentation. It's brilliant, and for your answers to the questions as well, which again I think was quite helpful. And thank you to everybody who's joined. We appreciate you taking the time out of your hectic diaries, and we hope you've been inspired in some way by this spotlight session. Just a reminder that if you want to find out more about evidence for QI, then please just do drop a note into the chat or respond to Claire on the meeting invite, and we can send more stuff to you. So that concludes this webinar. Thank you so much all for attending, and we hope to see you at the next spotlight session, if not before. Thank you.
Cheers. Bye-bye.